Everybody high. Central retinal artery occlusion CRAO is an acute ischemic event of the central retinal artery, a very small diameter and artery that supplies the inner retina and has minimal collateral circulation. Clinically, it is often described as an eye stroke, but pathophysiologically it is a directly observable model of small artery thrombocclusion, unlike most coronary or intracranial vessels, where the critical processes remain hidden. CRAO as a model of small artery occlusion. Because the central retinal artery is a small end artery, occlusion rapidly produces severe ischemia with a narrow therapeutic window and little capacity for collateral rescue. What makes CRAO particularly valuable for clinicians is that we can seize occluded vascular bed and its consequences in real time via ophthalmoscopy and retinal imaging. This allows us to test in a relatively poor setting how different systemic therapies behave in a small diameter artery with limited collateral flow. In this context, the recent randomized trial comparing intravenous Tenecteplase with aspirin in acute non-artery CRAO showed no superiority of thrombolysis for visual recovery despite treatment within the standard 4.5-hour window and even within 3 hours for a majority of patients. Functional visual outcomes were similar between groups, while systemic thrombolysis carried a higher burden of adverse and serious adverse events, including fatal intracranial hemorrhage. In other words, in this small artery and artery model, an aggressive clot dissolving strategy did not outperform a classical antiplatelet drug. Why aspirin deserves renewed attention? The key message is not simply aspirin is as good as Tenecteplase in CRAO, but why aspirin may be particularly suitable in these and analogous situations. Aspirin is unique in that it combines two critical actions. It acts as antiplatelet agent by irreversibility inhibiting platelet cyclooxygenase 1 and reducing thromboxane A2 mediated platelet activation and microthrombose formation. It also has a significant anti-inflammatory effect by modulating prostaglandin and related pathways, influencing the vascular wall and perivascular tissues. In occlusive arterial event, the damage is not purely mechanical, a plug in a pipe. The occlusion triggers a complex inflammatory response in the vessel wall and surrounding tissue, and reperfusion, spontaneous or treatment-induced, can amplify this inflammation. This inflammatory cascade combines to endothelial injury, microvascular obstruction, and secondary tissue loss during the recovery phase. In small diameter and arteries like the central retinal artery, where the fate of microcirculation and the quality of inflammatory resolution are decisive for functional recovery, aspirin's dual profile is particularly relevant. It not only reduces platelet-driven thrombus propagation, but also helps shape the inflammatory environment in which healing occurs. By contrast, systemic thrombolytics are focused on fibrin dissolution. They do not control the inflammatory component and add a non-trivial risk of systemic bleeding, including intracranial hemorrhage. Thus, CRAO offers a rare visible demonstration that in some small artery occlusions, a therapy addressing both thrombosis and inflammation, aspirin, can match or exceed the net clinical value of poor clot dissolving strategies. Extending the lesson to the cardiovascular system. The processes seen in CRAO, small artery occlusion, endothelial injury, inflammation-driven secondary damage are not unique to the retina. Similar mechanisms operate throughout the cardiovascular system at the level of small diameter arteries and arterioles, including distal coronary branches, distal carotid and cerebral branches, other end artery or poor collateral territories. For large artery occlusions with large tissue at risk, proximal cerebral arteries in stroke, proximal epicardial coronary arteries in STEMI when PCI is unavailable, there is robust evidence for thrombolysis in selected settings. These indications remain valid. However, CRAO reminds us that we should be much more cautious in extrapolating system thrombolysis to small artery or distal branch occlusion. Situations where the ischemic territory is limited but systemic bleeding risk from lytics is substantial. Clinical scenarios in which inflammation and microvascular integrity are central determinants of outcome. In such context, aspirin and more broadly antiplatelet-centered strategies may offer a more favorable risk-benefit balance than systemic thrombolysis, especially when combined with modern secondary prevention regimes. Repositioning aspirin in contemporary practice. Over the last decade, aspirin has been attacked in multiple guideline revisions, particularly in primary prevention, where the balance between modest vascular benefit and bleeding risk is rightly questioned. But the CRAO experience suggests that we should not generalize this skepticism to all settings and certainly not to small artery occlusive disease. From the perspective of CRAO as a visible small artery model, several points emerge. Aspirin matched a modern thrombolytic agents on functional outcome in an end artery occlusion that we can directly observe. Aspirin did so with a better safety profile and with a mechanistic plausibility grounded in both antiplatelet and anti-inflammatory actions. The same pathophysiologic logic applies in many small artery territories of the cardiovascular system, particularly at the level where clinical imaging cannot see what we can see in the retina. Therefore, it is reasonable to argue that for a partial return of aspirin to clinic focusing small artery ischemic syndromes, distal branch events where invasive reperfusion options are limited or unavailable, recovery phases where controlling inflammation and microthrombosis is as important as any initial reperfusion maneuvers. This does not mean indiscriminate use of aspirin in every patient, nor does it replace the need for individualized antithrombotic strategies. Rather, CRAO offers a clear, concrete examine that should stimulate the cardiovascular community to reevaluate aspirin's unique dual role and to design trials that directly compare antiplatelet-centered and thrombolytic or other aggressive strategies in analogous small vessel setting. In summary, central retinal artery occlusion as a visible small artery occlusion teaches us that systemic thrombolysis is not automatically superior. Aspirin's combined antiplatelet and anti-inflammatory actions may be particularly valuable in small diameter and arteries, and these insights are highly relevant when we think about distal coronary, carotid, and other small artery processes across the cardiovascular system. Thanks for likes and sharing.